sensory or motor loss, may feel electric shocks, and whatever they had goes away very rapidly. It can last up to 4 days. So let's say it's a kid on a football field who's playing pee-wee football and gets banged and knocked down, and he says initially he can't get up or move his hands. Would that fit into this criteria? So clinically, you got to suspect that he may have an injury to his spinal cord. Could be in the neck if it's from the neck down. If it's just his low back, maybe it's just in the lumbar spine. But these findings, just these few findings, should make you think that there's a spinal cord injury. Myth number 3, immobilization works. Well, you see these kids. Now, how many of these kids do you think would be this calm doing this to them? I mean, that's one of the big issues. Here's another one. Of course, this kid's acting, but I mean, look at this thing. Spine boards, now you know this from our recent change that actually has been coming along for years. We did, the medical directors for the state, and the state medical director organization, did a study and review of the literature and came out with a position paper 2 years ago saying there's no use for these. If you need them to get somebody out of a vehicle to help you get them out, that's fine, but they're not to stay on them unless you know for sure that there's an injury that requires them to be on a board. And to get the actual data, you can look at these original articles from 98, 99. In addition, I think the first time that I saw it in emergency medicine was back in 2000, and I don't know if it was Goldberg that wrote it, I don't remember. But they did publish an article about looking at this and finding no benefit. And actually, if you look at the ER literature, even up to 30 years ago, it says putting patients on backboards makes their symptoms worse, and if they didn't have a problem, when you put them on it, they would in 15 minutes. And that was published from an article that I originally saw in Annals of Emergency Medicine, and that was back in the mid-'80s. So there has been that thought going around for a while. It may hurt. Hurts because of the spasm you induce, the possibility of clots, of inactivity, of rhabdo in the older patient. How many times have you had a patient, maybe not down here so much, but up towards Fort Myers, they bring a patient into Lee Memorial, Cape, Health Park, and they sit on those boards for 2-3 hours on an ambulance stretcher. Or if they have an open stretcher, they'll put them on an open stretcher where nobody sees them for 2 or 3 hours. Don't you think that patient, especially these old people around here, are going to have a problem with that? I mean, that's how these people get other problems. Even pneumonias have been reported in the literature. C-collar, you know we recently changed to the X-collar. I don't know if that's better or worse. It was supposed to be better based on all the hype and the limited studies that were done. You guys have been using it for a year. Is it better or not? I think the consensus in general, now that it's been in use so much, is that it's not really any better than just using a plain old Philadelphia collar. And in the hospital, the neurosurgeons still use a Philadelphia collar. They don't use these rigid collars.
Seems to ride up on all patients.
Yeah.
It has to fit real. I mean, it seems like we need 2 people to actually put that X collar.
Yeah.
Always.
If you want to look at the actual data on cervical spine injuries, the most recent one being Journal of Emergency Medicine from 2013, Ensberg, Journal of Trauma, 2010. These would be something that you could look at and see what they found in their evaluation of these, and that sometimes it may actually create a distracting injury as opposed to stabilizing an injury. I've said a long time ago that the majority of your spinal deficits from a spinal cord injury are going to occur at the time of the injury, and that's what most of these find, except in instances where patients are improperly immobilized and they actually worsen whatever injury they had. As far back as 2013, a whole year ago, they again went through this and said you don't need to use it routinely. Again, it comes down to what we found in the state of Florida in immobilization. Here's some immobilization examples.
I like that.
Duct tape to the face and the airway, that's
He's got
how.
a non-rebreather on, he's all right. What the? It's Chinese.
I don't know what they were thinking there. I guess they figured, well, if they put a mask over them, it would be okay.
Hole in the duct tape.
Again, that's what she says. Mechanism alone warrants trauma. Now, you know in your trauma guidelines, you do have mechanism of injury, paramedic discretion. They're not used exclusively of everything else. They're supposed to be used inclusively with the age of the patient, you know, the nature of the trauma, the patient's complaints. All this said was that by and of itself, it is not a good indicator. That's all it says. But I don't think we've ever used it by and of itself. This, of course, I just had I had to testify in an abuse trial 2 weeks ago about a child that was being abused, and it still is a very, very difficult subject. There's no doubt in my mind this kid was being abused, but in the jury had to be convinced because, of course, the defense said, well, the area of this child's injuries are on his butt and the back of his legs, and that's permissible under Florida law to spank your kids and paddle them. There's a big difference between spanking a child and beating a child. And these weren't from spankings, these were from beatings. So, unfortunately, you know, it depends on the jury, but they did convict this guy and put him in prison for 2 years. Okay, so let's look at some of the data that they're talking about. Fact, number of deaths due to abuse is less than 5. That's 5 years old. Population is greater than MVAs and fires combined. You get that? Kids less than 5, the incidence of abuse with death is greater than all the MVAs and fires combined in the country.
Seems like those parents or whoever they are need more than 2 years. They need 20.
Yeah, well, unfortunately, you get what you get. I mean,
Yeah.
many do not have obvious findings on exam. In this child, he did, but because of the way children heal and the rapidity of the resolution of their bruising, you may have very limited findings after 2 days. And this child had been beaten the day before, went to his father's house and his stepmother's, and his father noticed something, and he looked at the child, and here he saw all these severe bruises, and the kid went on to explain what was going on in the household that he and his sister were enduring, and they brought him into the ER. But this had been going on for a year. He would make them stand in the corner and hold cans of beans out like this for hours, and if they dropped their arms, he'd beat them. They'd have to raise their arms back up. In addition, he wrote on the boy was 9 or 10, he wrote on his forearms, I am worthless, I am worthless, I am worthless. And he made him go to school and show everybody that he's worthless. So this is a systematic abuse. I remember the prosecuting attorney said to me, yeah, the stepfather's in the courtroom. I think, well, he's being tried, I would think he'd be there.
Yeah.
She said, oh, he's kind of big and he's intimidating, he's like 6'6" and 300 pounds. So I said, so what? I said, I'm going to say what I'm going to say, I don't give a shit how big he is. I said, what he did was wrong. And I showed the pictures, I got up, I walked over to where he was sitting, they had this thing set up, and I got my pen, and I pointed to where the abuse was and said, yeah, this was a beating, this was crushing of tissue, this is not a spanking, this is not discipline. I didn't worry about it. And this is really the crux right here. If you're not inducing a crushing injury to the child, yeah, this should be crushing. You shouldn't have bruising. Yeah, it's just a misspelling. So, in order for you to get these big bruises, you gotta really whack hard to crush that tissue and release the heme that's in the red blood cells, to fracture the muscle fibers in that tissue. You know yourself, you can bang yourself and just get a little tiny bruise. But when you have a bruise that's this big on each buttock in a 10-year-old, that's not from somebody whacking them once or twice. Especially when they're deep red and the other bruises on the rest of the back of his legs are starting to change colors into purple and blue and brown and yellow and green as the breakdown products from muscle rupture go through their normal process of healing. These are ALTEs are where they stop breathing for a second. Okay, or they turn purple. It means apparent life-threatening event. And these are some of the things that an observer might report to you. Apnea, color change, change in muscle tone, choking, gagging. I would not suggest to you that if you get a call like this, that you don't transport this kid. They should be transported and evaluated, because you don't really know what's going on. And you can't, when the kid's not doing it at the moment, you don't know what happened to that child. They could have aspirated something, you may not see it may be too early. It could have been an abuse, you just don't know. So if you have a situation that presents as an apparent life-threatening event, or what it means is these things here, then that child needs to be evaluated at the hospital and observed. High risk, there's symptoms at the time of the evaluation. There's bruising, and they're talking about specifically the head and whatnot. There's a history of any kind of apparent life-threatening event in the last 24 hours. Oh, my child stopped breathing yesterday when he was napping. The last thing you want to do is get called for a respiratory emergency or a choking episode in an infant, and 2 days later get called for a SIDS death because you didn't transport it. You take them to the hospital, you let them deal with it. And of course, here it even talks about a history of previous apparent life-threatening events or SIDS events in siblings. This was not known until about 20 years ago, 30 years ago maybe, that they said that if there's a SIDS death in one sibling, you have a higher incidence of having it in subsequent siblings. So you had to consider, because they don't really know what causes it. And again, high risk, less than 6 months, but even more so, less than 3 months. Does that mean they're going to find out what it is at the hospital? Not necessarily, but they more than likely will at least observe them for a period of time or admit them. So we all know this already with asthma, especially in kids, but this is also true for adults. You can't tell if they're going to be cleared up and be fine, or if they're just going to all of a sudden get much worse. Again, another one that should be treated and transported. Shouldn't be released at the scene. Because asthma in anybody is life-threatening and does happen very rapidly. I've seen patients come in, they seem like they're getting better, and within seconds to a minute, they're significantly worse and require intubation. So it does happen. This is a change in the last few years about epi, and there's still, I may have mentioned this before, there's two schools of thought with this. And the studies have supported the fact that those that did not get epi for an acute allergic reaction went on and developed problems and subsequent anaphylaxis. So it is something that has become more routine to use in the field now. They give it IM, usually at a dose of 0.5 for an adult. Some people, some of the attendings there and directors of these programs and EMS units recommended 0.5 for everybody. However, there was also about 30% of the people that said no, it should be 0.3, you don't need 0.5. And it should be IM, everybody was in agreement that it should be IM. this makes me laugh. And the reason it makes me laugh is because I can't tell you how many times I get a chart on a child and there's no blood pressure on it. And I say to the nurse, where's the blood pressure? Oh, I didn't take it. Why? Oh, well, you know, they're always okay. I said, no, you need to take the blood pressure. I said, it wouldn't be there if it wasn't important. You need to take the blood pressure. And the last statement is where I alluded to before, children are not little adults. Well, in fact, they are little adults. Yes, the dosages are weight-based for their meds. Their physiology and their anatomy is a little different only because of their shape and size. Their head does make up a larger percentage of their body surface area. They do have immature livers, so that many times medications work a little bit differently, but not to the point that you have to not use them. You just have to be aware that their characteristics of the metabolism of the drugs may be different, so the dosing has to be pretty specific. And that's probably more true than anything. Adults are big kids. So we'd still do our history and physical, ABCs. Hey, there's Jason in that picture. Okay, if you want to get, this guy has a lot of lectures. This is just one of them. But I think he lectures pretty much every year there. I've only been to a couple of these. It's worthwhile to go, though, because there's things that you're going to see. All right, let me see if I can wreck his computer now. Okay. Now, these are the top 5 articles for 2014, and then we're going to have the top 5 articles that should be burned that still have influence in the literature, and that's important to understand because some of this is where this current trend that you see in CPR and all this stuff comes from. So, having said that, let's look at the, oh, you know what, I'll back this up so you know where this came from. This is from Dr. Slovis. A lot of articles, a lot of lectures he gives at this conference. So you see, again, he comes from a university medical center, big city, Nashville Fire Department. Again, fire EMS, not separate systems. And if you want to go to this website, VanderbiltEM.com, you can go there and you'll see that he has these links. You can't download them off this presentation. You have to actually go to VanderbiltEM.com, and then you can go to Dr. Slovis. You can look for conference handouts, and you can pull up some of his lectures. You see he's got CPR updates, EMS articles that he felt were important. I can't read this. Oh, most important EMS articles. Most important, I don't know what that is, non-EMS articles. These would be good things, you know, when I tell you to do a presentation on something, this is the kind of stuff you want to look for. All right, this is something that will educate you, give you a little more information. Doesn't necessarily mean it's state of the art. You have to look at these things. You always have to look at these articles in a quizzical way because they're not 100%, and we'll talk about that as we go through these next 2 little segments. So, epinephrine and CPR. Now, you know AHA has changed these guidelines. They've changed ACLS. Treatment guidelines started, epi was given in 1 milligram doses. Within 5 years, instead of it being 1 to 10,000, it was 1 to 1,000 given in 5 milligram doses IV. And that was in vogue for a while because you always got a pulse and a blood pressure of the patient. The problem was you also got cerebral vasoconstriction and brain death. So this is the article. It's evaluation of pre-hospital administration of adrenaline and epinephrine by emergency medical services. Emergency medical services for patients with out-of-hospital cardiac arrest in Japan. Now, here's some issues right off the bat that you should know when you see articles like this from a different country. Their EMS process is not the same as ours. Okay? First of all, because Japan's more of a socialist country, everything is gathered as data. These are all done retrospectively, but there's no double blindness to them, meaning that the researchers know what the results are going to be because they're right there. They know who it is. They know all the predisposing factors. They didn't just randomly choose who they were going to give epi to. So,
Aren't they partially blind because they're Japanese?
only if they're really skinny. Another thing in Japan is there's tiers of medics. Okay, so epi is not given by the routine medic or even the P2 medic. It's usually given by a senior medic who has a lot of experience, special training in the use of drugs and procedures. So it's not routinely used by just the guy on the street kind of thing. So what did they look at? They looked at, well, does epi have any benefit during CPR? They did a retrospective study, which means that they used data that they already had. They just went back and formulated criteria for admission or exclusion to the studies. They used pairs of out-of-hospital arrest patients. I don't know why they chose that. They matched them for epi versus non-epi therapy. Okay, so what did they find? Well, what were they looking at was a couple of different diagnoses. They looked at VFib, VTAC, epi versus no epi. They looked at survival and whether the neuro was intact. Now this is interesting because some of this is legitimate and some of this is what we have found in studies in this country. And there's a lot of data that comes out of Japan. I just don't know how accurate it is and how applicable it is. So sometimes you got to think about it. Can you see that? Okay. So let's look at these numbers for a minute. So survival with no epi was 13.4 per 20 patients. Okay, it should be 100 patients, but they don't have it graded that way. It should be per 100 patients. Neuro intact, only 6.6%. Epi, when that was used, what's the neuro intact? 6.6%. What's the survival rate? Well, you know, if it's greater than 10%, it might be significant, but there's no change in neuro. So what's that tell you right there? Tells you they were brain dead with no epi, they're still brain dead with epi. That's what it means. They had no neurologic improvement. So epi made no change in the outcome. Remember what I said about epi, what it does to the brain. They looked at asystole and PEA. They had 9,000 pairs. I'm sorry, they had 1,990. Okay, so this is a percentage. That's my mistake. I forgot that was a percentage that we're looking at. So now they had asystole and PEA, and they used no epi patients. Survival was 2.4%. Neuro intact was 0.4%. They used They used epi, same group of people. Survival rate was 4%. Well, maybe 1% difference. Neuro intact, really considered no different. So again, we come to the same conclusion that in these rhythms, VFib, VTAC, asystole, and PEA, the use of epi does not seem to protect them neurologically. The authors say, okay, our study showed some favorable effects of pre-hospital epi. Absolute increase in neurologic intact survival, however, was minimal. So if you looked at that and didn't read those numbers in that data, you would think, well, we should give epi because people survive. But the point was they didn't survive neurologically intact. So what is exactly are you living? The other thing is, we don't know if this was a 30-day survival, a 24-hour survival, a 6-month survival. We have no idea what this was because they didn't put that in there. So we don't know what this means by survival. The only thing we can absolutely say is that for the most part, as this author says, this does not show any real benefits in the vast majority of patients. Another one. Vasopressin, steroids, and epinephrine, a neurologically favorable survival after in-hospital cardiac arrest. So what they did, and I can't read the top portion of this, is they looked at, I forget how many patients. Do you see a number over here to say how many
That's just
patients?
all the doctors.
There should be a number somewhere in here. Anyway, they looked at this group of, oh, here it is, I'm sorry. 268 consecutive cardiac arrests. 3 Greek tertiary care hospitals. Medical care in Greece is what? Socialized medicine. So they get all this data because like Obamacare, you gotta have all this ID stuff and your demographics and they know all of this. Now, this is supposed to be randomized, meaning they just picked people out of a group. Double-blinded, they didn't know who had what, who had predisposed conditions, who didn't, and placebo-controlled, meaning that some people got this and some people didn't, and the people giving the meds didn't know who was getting it and who wasn't. And when you don't have to worry about being sued, I guess that's okay.
Basically like human trial then.
Yeah, for the most part. All right, I'm going to sit over here because I have to be able to move this thing. So what did they find? Well, let's see. They want to know if using these 3 drugs is going to change anything. So what did they do? They had these patients divided into 5 cycles of resuscitation. Okay? And they gave them periods of 3 minutes of resuscitation. And they had one group that just got epi, and they had another group that got epi, vasopressin, and solumedrol. Now you notice the solumedrol is only once. And when we give it, we usually just give it once. We give it at a higher dose for breathing issues and allergic reactions, but they used only the 40 milligram dose. I don't know how they came up with 40 milligrams. I do know that when we admit a patient to the hospital and we're giving them solumedrol IV, during their stay, they get 40 milligrams 2 or 3 times a day. So they may have chosen to use an average hospital dose. You can look this up in JAMA in 2013 if you need to. You want to look at it more in depth. So return of spontaneous circulation after 20 minutes, epi versus the combination of vasopressin, steroids, and epi in cardiac arrest. What did they find? Well, with the epi alone, 65.9% had ROS. With this cocktail, 83.4% had ROS. Pretty significant difference. You know, that's like over 20%. Well, out of those patients, how many were discharged home? Remember I said in the previous study that they didn't tell you who survived, who went home, and that's what this is talking about. How many patients survived and were discharged after this combination? Epi alone, 5%. vasopressin, steroids, and